Hey guys, welcome back to the Best Practices Show, where my name is Kirk Behrendt, and I'm your host where we're going to bring you best practices from the best practices all over the country. And I have a good friend of mine here who you've heard before on the podcast, Tom Viola, and we're going to be talking about, can my patients say I've become comfortably numb? And we're going to open this up in a way that you're going to see. If you haven't heard Viola before, you're going to want to hear this now, because he is just an incredible educator, brings a whole new dimension to education, and it's wildly entertaining. So make sure you stick around for this. Now, a couple show notes before we get started. If you're a podcast listener, I'm always going to encourage you to do one thing. If you're listening on Spotify, Stitcher, iTunes, whatever, do me a favor. Go down to that subscribe button right there and just click the subscribe button, because I want you to show up every single week. You're going to see every single week, we're going to bring you a brand new expert in dentistry that's going to give you some new thought processes, best practices. That's what the show is called, Best Practices. And you're going to see and hear what some of the best thinkers are doing and teaching, just like you are today. And I don't want you to miss out. So if you subscribe, you can keep showing up over and over and over again, and make sure you tell your friends. Number two, some of you are asking, like, what the heck do you guys do? Well, we're practice coaches. We are crazy excited about education, learning all these things. We coach dental practices. So here's what we do. If you're a dental practice owner and you're like, I don't know, it's not as easy as it used to be, I think things could be better up here, give us a call. That's what we do. Or if you don't want to write off so much to PPOs anymore, give us a call. That's what we do. If you want your team to get along and you want to enjoy coming to work in a way that they enjoy you and you enjoy them, that's our specialty. So check us out at actdental.com, where we help you create a better practice and a better life. Part of that is learning what the best practices do. Oh, one last thing. If you're not subscribing to the Best Practices magazine, what are you thinking? Check it out. You're going to see we put the best minds in here. A lot of the people that we interview on the podcast, you're going to see Viola is going to be in there. Our goal is to help the private care practitioner. So it's our way of putting out great information so that you guys can be energized about really doing the right things in dentistry. Make sure you check it out, actdental.com/magazine. Hey, it's free too. So check it out. So Tom, you've been on before. And yes, I love having you on here. I'm going to have you here and hang out a lot more. And when I see you on the road, I'm going to put you at a headlock and we're just going to hang out and have a couple cocktails together. But I've really come to enjoy you. And today we're going to be talking about the anesthesia or anesthetic part of dentistry that a lot of dentists are still kind of second guessing themselves when it comes to this. But I always like to do this. Let's start here. Like, somebody doesn't know who you are. I want them to know who you are before we get into the what and the how behind this.
Sounds good. I will tell you, Kirk, by the way, I am actually subscribed to the podcast, but I don't tune in on the days when you have that guy Viola on. I can't stand listening to him anymore. So all the other great speakers, absolutely, but not when that Viola guy's on. So tell him I said, sorry, you're too much.
Deal.
So, who is Tom Viola? So I started out as a pharmacist. That's how I began my career. And after about 10 years, I realized I just didn't want to do it anymore. I love my patients. I love the practice. I love the profession, but I just thought that I could do more. And so I specialized in pharmacology and then specialized in dental pharmacology. And it's been a great lesson. I think I told the story a couple of times that one of the incidents that convinced me to move into dentistry was the fact that at the time I was deciding which specialty I was going to choose, I had an appointment with my dentist. Nice guy, still know him, we still have friends. And he at the time told me, pharmacology, dental pharmacology. I said, yeah, that's what I want to specialize in. And he said, I got news for you. He said, I don't even remember the course. He said, I took the course. It was early in the morning. I was asleep half the time when I showed up. And when I didn't show up, I was asleep in my bed. I never paid attention. And I crammed for every exam, got through with like a C, and basically said, I never want to see that course again. So if you're going to ask me about pharmacology, I don't know the first thing about it. And that's when I realized, wow, this is where I belong. It's tough for dental professionals to take pharmacology and make it applicable and practical to their everyday practice. And that's what I wanted to do. That was my mission in life. That's why I formed Pharmacology Declassified. The company was formed on the foundation of pharmacology is not easy. No one likes the course. No one wants to take the course. There are some people who find a certain, connection to it, but the majority of professionals I've dealt with have said, it's just too much. I don't have time, and it's too complex and too cumbersome to really understand. It's full of jargon. I just wish somebody could make it easier. Not because dental people are simple-minded, don't get that idea. It's because they want something that's easy to use. It's like that instrument, you always have that favorite instrument you love so much because it's easy to use, it's always at hand, and you're comfortable and familiar with it. Well, that's my job with pharmacology, to make pharmacology that comfortable, easy to use instrument you can use every time. And if I'm not doing that in this company, then I'm not doing my job. My job is to make this whole world of pharmacology fit into bite-sized pieces that you can use to get better outcomes for your patients, because that's why we're there, right? The whole point is to deliver good dental care, but also to keep our patients' interests, best interests at heart, and protect them and keep them safe.
Yeah, well, I have to tell you, buddy, you do your mission extraordinarily well in so many aspects, and you guys are going to hear that today as Tom gets into his stuff. But this is a moving target, and this is too much to think about. Like, with all the things that are going on in the world in this department, I'm just going to tell you guys, he makes it very interesting. I mean, heck, I can understand a quarter of what he's saying, so that should tell you a lot. And then number two, it's like it's entertaining. You've taken the dry part of education, a big part of it, and made it very entertaining. If you're a study club director, just like Dr. John Wallace last week, ask him in Dallas, Texas, get Viola to your study club. He will help you. Your club will love it, number one. Number two, he's going to help them with stuff that's actually relevant and super useful right now. So check it out and make sure you get it in. And Tom, let's talk about the why before we talk about the how. When you're talking about, I love your play on, song titles too. Last time we used the movie title Up in Smoke when we were talking about cannabis, but now we're using a song title to kind of add some flavor to this. But when we say, can my patient say I've become comfortably numb? Let's talk about why this is so important.
The reason is all about one thing: pain. Pain is a demotivator and a motivator for our patients. For some people, they get it. Early on, they realize every time I wait to seek dental care, I end up in more pain and have poorer outcomes. It hurts more, it lasts longer, and so that makes me not want to go back. So let me just go to the dental office as soon as I start to feel the first twitch of pain. Let me get in there right away. Let me get it addressed, because the faster I address it, the less pain I'm going to be in overall, and therefore the better the outcome for me. But sadly, that's a smaller percentage of your overall patient population. The larger percentage, which I deal with every day in the clinic and my students and as a pharmacist too, people, smart, logical, bright people who seek out an orthopedic doctor if they have a pain in their shoulder they don't recognize, or a neurologist if they have a pain in their head they don't recognize, or a gastroenterologist if they have a pain in their abdomen they don't understand. These are the people who will seek out help immediately. But when it comes to dental pain, sometimes say, let's see how bad it gets first. What kind of strategy is that? Why would a level-headed person who seeks out help for everything else wait for dental care? And the answer is because they're making a qualified decision. The previous experience they had in the dental office was so horrendous in their own minds that, this was the pain they were in last time. This is the pain they're in now. And it's like, okay, well, let's see how bad it gets. Will it ever rise to this level? Then I'll go. Well, what ends up happening is usually if they don't get treatment, pathology persists, and eventually the pain gets to where it's even as bad or even worse than last time. And now it's like, okay, let me go. I got to get this addressed. But by the time they come see you at that point, they're hyperinflamed, hypersensitive. Good luck getting them anesthetized, and good luck treating their perioperative pain with anesthesia. Good luck treating their postoperative pain with analgesics. So what's my overall impression of that dental appointment? Oh, it sucked, and I don't want to go back there again. When in reality, it wasn't the dental professional's fault at all. It was just because you waited too long. So why are they waiting? Pain. So if we can effectively and efficiently manage perioperative dental pain with anesthetics and postoperative pain with analgesics, if we can get that pain to be not a bad memory, but a memory, then they won't be so fearful next time, and they'll come back sooner, and we won't have this vicious cycle of pain being a demotivator and actually making the situation worse over time.
Yeah, absolutely. And what are some of the natural pitfalls dentists run into when it comes to this. It's anesthesia has been a challenge for dentists as long as I can remember. And now it's even more complex, or there's a lot more variables involved. I mean, what are some of the big pitfalls you experience with dentists all over?
Well, I can tell you the two things I could never teach, Kirk, and I don't think, unless you're a practicing clinician and you do this every day, you don't learn this in a classroom. And the two things are accuracy and technique. Yes, somebody can show you, guide your hand when you first learn how to inject, but I could never teach anyone technique and accuracy, because those are the skills you hone in years of clinical practice. So it's not just about the anesthetic agent at the end of the day. It's what technique you use to apply that anesthesia, and how accurate you were in deposition of that anesthetic agent that really makes the difference. And so as much as we like to quote unquote goof proof the anesthesia portion of dentistry, those two things will always be obstacles. One, because our technique is our technique. Sometimes we're a little more rusty than others. We get it. And the other thing is anatomy is different from patient to patient. So based on landmarks and what you know to identify as a landmark, the deposition of the anesthetic may be on target and maybe not because of their individual anatomy. So those are the challenges that we face. Now, some of the other challenges like infection can be addressed sometimes, in advance, let's say with antibiotic medications like antibiotics to prevent or to reduce bacterial load. But sometimes it's choosing the right technique for the individual procedure. Again, I don't like to speak about that because at the end of the day, I'm not that sort of dental clinician. I focus more on the agents themselves. But if you were to move technique aside and say, okay, I got my technique down, I know what technique to use for this patient in this procedure, and you can remove accuracy as an issue and say, well, I'm pretty accurate, I'm pretty good at picking out landmarks, and I'm almost dead on every time, then it really boils down to the actual agent you're using at that time. And the challenge, I think, beyond technique and accuracy is, am I using the right the right anesthetic for the right patient at this right time? Am I using the right anesthetic agent for this patient based on their particular medical history and what medical complications they may have? And that's the issue. Do you know the pharmacology and therapeutics of anesthetic agents that we use in dentistry every day enough to say, okay, for this patient who has, this issue medically and has this issue from a dental standpoint, what's the anesthetic agent I should choose? Okay, I'm going to use this one. If you know your anesthesia pharmacotherapy as well as I think you do, and you're able to pick that anesthetic agent out, great. But this show and shows like this and courses I teach like this are all about, if you don't know, here are the benefits, here are the advantages and disadvantages of each anesthetic agent, so that it'll help you choose the right anesthetic agent for the right procedure for the right patient.
Yeah. So let's talk about one of those, agent situation. Let's say we have the right scenario, the right age. What are some of the threads that you're talking about with dentists when it comes to these scenarios, and maybe for instance?
Well, first thing you have to overcome is the fact that everybody still believes you use Novocain. Yes. Ask anybody. They'll say, I still, you guys use Novocain, don't you? I mean, even Bon Jovi sings a song called Novocain. I felt like calling him up saying, John, it's Lidocaine, okay? Because nobody uses Novocain anymore. But why? If the whole world believes we use Novocain, then why don't we still use Novocain? And the answer is because we don't use ester anesthetic type agents anymore. And the answer for that was because esters caused allergies. Not in everybody, but in some people they did. And so Novocain, for example, a Procaine, was allergenic because it was broken down in the bloodstream to an item called PABA, paraminobenzoic acid. And patients were sensitive to PABA. Now, think that through and realize, okay, I gave the patient Novocain. I trust ester-type anesthetic agents, because they're broken down in the bloodstream and they don't need good liver function. So I don't have to worry about giving a patient with not so great liver function this anesthetic agent because it's broken down in the bloodstream. 2 thumbs up, right? Problem is, if it's broken down into something that I'm allergic to, it's the equivalent of me getting an IV injection of an allergen that can lead to devastating results. So how can you run a profession like that using an anesthetic agent that may or may not cause a severe allergenic response? we moved away from the esters. I mean, we still use benzocaine and tetracaine and topical anesthetic agents that are ester-type anesthetic agents, but we moved away from the esters to the relative safety of the amides. And of course, our choice was lidocaine. Okay, so by moving to the amides, we got relative safety, right? Very rare for someone to be allergic to an amide. It exists, but it's rare. Okay, so let's go with an amide. But now we gave up the specific therapeutic advantage of what? Amides are not broken down in the bloodstream. They're broken down in the liver. So you have to have good liver function to break down lidocaine, mepivacaine, bupivacaine. And that's the way it was really until Prilocaine was introduced, where Prilocaine was metabolized outside the liver to some extent. Basically, alternate sites were like the lungs and the kidneys. But the jewel was Articaine. When Articaine came along in 2000, it was the prototype for what we thought was success in anesthesia and dentistry, because it was an amide that was broken down in the bloodstream like an ester. So you got the benefit of the amide, right? Lower allergenicity, but you didn't need to worry about the patient's liver function as so much. So it's all about the type of anesthetic agent and making sure the patient understands that the anesthetic agents we're using, for the most part, are honed to perfection based on their specific needs. So I wanted to see if we can go through each anesthetic agent, Kirk, and like see what the benefits and disadvantages are of each one, to kind of give everybody a way of choosing ultimately which one they're going to use.
Let's do it. Let's do it.
Let's start off with Articaine. Not because this is a commercial for Articaine, but because, let's face it, it's Articaine. When you ask anybody, why do you use Articaine? What's their answer? Because it freaking works. I mean, that's what everybody says. But why does Articaine work so well? What is it about Articaine that makes it special? Okay, so a couple of things. Number one, yes, it's an amide that's metabolized in the bloodstream like an ester up to 95%. So you can give it to a patient whose liver function isn't so great, and it's metabolized fairly well. Okay, now again, everything I say in these podcasts is never going to supersede your clinical judgment. Okay, so don't say, oh, Viola said I can use Articaine in patients' liver dysfunction. No, I'm saying you can, but it's your choice. Okay, you've got to know the patient well. You're intimately involved in that patient's care. I'm not. But assuming a generic patient with liver function that's not so much, I would probably, along with my colleagues, would say, well, I think Articaine would be a good choice there because it's broken down outside the liver. Wonderful. The other part about Articaine that makes it special is that it is incredibly fat soluble. Now, that whole concept kind of eludes most people because that's that part of pharmacology that seems to be so jargon rich. Basically, you learn one thing in pharmacology. If a drug's going to work in your body, it has to cross a membrane at some point. Okay? If a drug doesn't cross a membrane, it's going to go in and out of you, giving you no benefit at all. Kind of like corn. Okay? If you don't know what I mean by corn, have 3 cans of corn tonight after dinner, and you'll know what I'm talking about tomorrow. But anyway, so you got to be able to cross a membrane, right? All right. So that means you, as a drug, have to be fat soluble, because your membranes are phospholipid, right? Phospholipid membranes, you need to be lipid to cross the membrane. All right, got it. Articaine is incredibly fat soluble. It crosses membranes and therefore penetrates into tissue better than most anesthetic agents because of that fat solubility. So it penetrates deeper. It reaches areas that other anesthetic agents may not because it's so fat soluble. And the fact that it's 4% scares some people, because we've all heard that you can't use 4% anesthetics in mandibular blocks because it's likely to cause paresthesia. I totally get that. I'm not even going to be here to debate that today. But the point is 4% means what? It's twice as concentrated as lidocaine. That's twice as many molecules in that little cartridge that you get in a lidocaine cartridge. So you've got a better agent as far as fat solubility and more fat soluble molecules, and you've got twice as many molecules. So of course it's going to work better, and that's why we love Articaine. The downside to Articaine, notwithstanding the fact that it works pretty quick, okay? The downside is Articaine is not available plain. So if a patient has a sensitivity to epinephrine or can't use epinephrine for a medical reason, you can't use Articaine because it's only available with epinephrine. Okay, so here's the plus and minus, okay? Patient has liver issues or, cirrhosis, hepatitis, some type of liver disease, okay? Okay, so Articaine seems to be pretty well suited for that. This is going to be a really invasive procedure, a third molar extraction, that kind of thing. I want to do a long buccal. I want to do infiltration, whatever. Okay, I'm going to use Lidocaine, right? Because it's 4% and it's fat soluble. Remember, your patients have an expectation. It may not be reasonable, but their expectation is what? The minute you retract that needle, the second you pull that needle out, they're thinking, okay, the clock's starting to tick. I should be anesthetized in no more than a minute. Okay, now we all know that may not be realistic. Sometimes it takes longer for anesthetic agents to set up and start working. But Lidocaine works in about 1 to 2 minutes via infiltration. So it almost delivers on the promise. By the time you're retracting that needle, I'm starting to feel, wow. Why is that important? It's my confidence in you as the clinician. If my expectation is I should be numb in a minute, and I'm not numb after 5, I'm not blaming the anesthetic agent. I'm blaming you. And I'm saying, you suck. That's what I'm saying. I may not say it out loud, but that's what I'm saying. And my confidence in you has eroded to the point where I don't even trust you. I may get pain later in this procedure. I don't know. I may not be here next time. So Lidocaine delivers on the promise, and all of a sudden I'm numb in about a minute, which is my expectation. I'm thinking, wow, you're awesome. See, it wasn't you, it wasn't me, it was the agent. And that's why I think we love Lidocaine so much. It takes away some of the anxiety. Okay, so that's the pluses. But this epinephrine thing is a disaster, isn't it? Well, it depends on what you mean by whether or not the patient can use epi. I love this because when medical doctors say to me, and when I'm in a clinic with my students, no epinephrine for this patient, no epinephrine. I'm always laughing on my side of the phone. Respectfully, I keep it on mute, but I'm always kind of cracking up because I'm thinking to myself, your patient's taking a bath in epinephrine. They're completely, fully loaded with epinephrine right now because as dental professionals, we are familiar with the dental office. We practically live there. For some of the people listening to this, you probably do live there. I mean, you spend more time in the op than you do at home, let's say. So you're used to the whole experience. You are at home in a dental office. But for your patient that's there twice a year, they walk in, it's a foreign land. They see things they're not supposed to see. They hear things they're not supposed to hear. They smell things they're not supposed to smell. Then they sit in the chair, they're all tense, and you put a bib on them, and they're like, what are we having, lobster? No, little pieces of tissue and blood are going to fly out of your mouth while I'm working on you, and it might stain your clothing. If that's not enough to put anybody on edge, I don't know what is. So, of course, they're swimming in endogenous epinephrine, their own adrenaline. Is the amount of epinephrine you're going to use in a cartridge enough to push them over the edge? Maybe it's a match on a pile of dry grass. That's the thing. So we try to be cautious with the use of epinephrine. And unfortunately, Lidocaine is not available without epi. So you can have Lidocaine in 2 flavors, with epi or with epi, the 1 to 100,000 or the 1 to 200,000 dilution. And that means patients who can't use epi because the doctor says no, patients who won't use epi because they just won't, they feel they're sensitive to it, or patients with a sulfite allergy, rare as it is, can't use any cartridge that contains epinephrine because all cartridges of anesthetic that are made in the US or abroad that are shipped here that have epi contain sulfites as preservatives. So there are times when you can't use epi, and that rules out the use of Lidocaine because it's only available with epi. Now, if you're asking yourself, well, why don't they make it without epi? The answer is Lidocaine is a very potent vasodilator. What does that mean in any other language? It means it makes all the blood vessels in the injection site do this, which means your anesthetic agent goes, and that shortens the duration of action. So because Lidocaine is such a significant vasodilator, you have to use epinephrine to constrict. Now, one footnote to that is the fact that Lidocaine is available in that 1 to 200,000 dilution, which in our vernacular means half strength, right? We're all used to 1 to 100,000 being our regular strength. 1 to 200,000 would be considered half strength. The manufacturer of Septicaine says we should be using 1 to 200,000 because really, and even Dr. Malamed, other experts in this field will say, we should be using the 1 to 200,000 because the 1 to 200,000 at half the strength of regular 1 to 100,000 epinephrine still gives you the same effect without adverse effects. So why not use the 1 to 200,000? So I look at Lidocaine as a mixed blessing. It's got huge advantages and therapeutically, but the epinephrine is definitely an Achilles heel.
Awesome. What are some other popular agent conversations you hear as you're talking to dentists?
The debate over lidocaine versus mepivacaine rages on. Okay, so what should I use? Should I use lidocaine or mepivacaine? Okay, should I use xylocaine or carbocaine? Okay, lidocaine is the gold standard. Everybody knows it. Okay, lidocaine has been the gold standard since forever. Why? Well, number one, because it was introduced first. Okay, it was our first amide. But number two, it has a long, impressive record of reliable and safe use. People have been using lidocaine for, decades. So when you look at it, you can say, okay, there's a good reason why lidocaine is our gold standard for that alone. But let's face it, every office uses lidocaine. It's almost the Kleenex of tissues. Like, you can say lidocaine, and everybody understands what that means and how it works, etc. Okay, so that's great about lidocaine. But lidocaine took a serious hit earlier, in like the early 2000s. And what was it? Lidocaine used to be available a couple of different ways. It was available with 1 to 50,000 epinephrine, which is now twice as strong as what we normally use at the 1 to 100,000. It's available to 1 to 100,000, which almost everybody uses. But it was also available plain. It's no longer available that way. Not many people remember that. You got to be as old as I am to remember lidocaine plain. So what's the problem? Well, lidocaine is considered the gold standard. It has a long, impressive record of reliable and safe use. Heck, go walk down the aisle of Walmart or Target and find, a first aid cream that treats pain that doesn't contain lidocaine. It's getting pretty rare now. Lidocaine, even your patients know what lidocaine is. Okay, everybody knows about lidocaine. They wore the patches on their elbows and their knees for pain, so people are familiar with lidocaine. But the therapeutic advantage of lidocaine, beyond the reliable and safe use, was the fact that it was category B. Pregnancy category B meant, very plain language here, it was safer to use for a pregnant woman. Pregnant men are on their own. It was safer to use for a pregnant woman than, let's say, Lidocaine or even Bupivacaine, because they were considered category C. Now, that's at least according to the FDA pregnancy standards. Okay. So that was lidocaine's claim to fame, right? But there's a problem. Now, what is it? Okay, not every pregnancy is a good, candidate for epinephrine. Like, you can't always use epinephrine in pregnant women because some women have preeclampsia, and so the epinephrine becomes a liability when you use lidocaine in a pregnant woman if that woman can't tolerate epinephrine during her pregnancy. Okay, what to do? So I've got a category B drug. The FDA says it's category B even with the epi. So what should I do? I can't use, well, if the doc says no epi, then it's no epi. So then what should I use? Well, that's when we shift gears and say, well, we should use Mepivacaine. Now, Mepivacaine, also known as carbocaine, is plain, right? Everybody knows that. So 3% plain Mepivacaine. Okay, sounds good, right? It's plain. And it's 3%. So it's 1.5 times the number of molecules that you'd get in a 2% lidocaine. Sounds good to me. No epi. No. Perfect. Okay. But while it may be a great drug, and it is a great drug, the problem with Mepivacaine is it is epinephrine free, which means it doesn't last long enough. So paint this scenario, okay? You inject a patient with Mepivacaine. Now, how long does it last? Let's say 40 minutes, okay? The procedure lasts longer than that. So around maybe 40 minutes, the patient might be saying, I'm starting to feel something. Okay, when they start to feel pain, this breakthrough pain, because the anesthetic's starting to wear off, they get what? A surge of epinephrine from their adrenal glands, right? Adrenaline, because they feel pain. What do you do with that situation? Well, oh, hold on a minute. And you break out the needle and, well, got to give you another round of injections. That's another surge of adrenaline, right? And then, now they've had pain the first time, and now they're, they don't know how long the procedure is going to take. So now they're on edge, like, okay, if this procedure lasts as long as the first half, I'm going to be pain again. Another surge of adrenaline. So you can make the argument, many people do, that the patient's actually getting more epinephrine because you didn't use epinephrine. Like, if you just used epinephrine in the first place, the anesthetic would last, let's say an hour and a half, and you would have been done in an hour, and it's all over. So I don't know. It's 6 of one, half dozen in the other. But the point is, if you're thinking Mepivacaine is a safer choice in that situation, this is where a consult is necessary, especially during pregnancy, because again, we don't know. As a category C, is Mepivacaine safer because it's plain, or should we go with lidocaine, which is category B plus the epi? So what have I seen in my experience? I've seen most clinicians go with the Mepivacaine, even though it's category C, because the no epi thing is considered advantageous. But keep in mind, it may be ideal if you're going to work on a patient who's pregnant to keep it to shorter appointments so that you don't run into that breakthrough pain, so they don't get that surge of endogenous epinephrine. And I'm going to tell you, a lot of docs will say this, that a patient in pain, a pregnant woman who's in pain, expresses things like cortisol and oxytocin, which could be problematic during pregnancies. So if we're going to use Mepivacaine, let's make sure we use it wisely in a pregnant patient. Okay, but forget pregnancy. Let's talk about a patient where the medical doctor says, no epi for you. Or the patient says, no, I don't want it. Okay, then what? Well, now you've got to choose between the lidocaine and the Mepivacaine. Okay, so you can't get any lidocaine plain, you're going to go with Mepivacaine. But is Mepivacaine right for that patient? Are there situations where carbocaine plain, Mepivacaine, may not be ideal? And I can think of one right off the top, which is, depending on the patient, let's say it's a pediatric patient or a geriatric patient. Mepivacaine may be a great drug, but it's one of the most difficult to metabolize. And so you can easily create a perfect storm with Mepivacaine if you're not careful. What's the perfect storm? You're going to give this Mepivacaine, this carbocaine plain, and you're going to give it in sufficient quantities because it's going to run out, it's going to wear off in like 40 minutes or so. You're going to give it in sufficient quantities to make sure you get good penetration, profound anesthesia. But the perfect storm arises because now you've given this anesthetic agent, which is the most difficult to break down, to a patient who, based on whether it's pediatric, geriatric, or someone with compromised liver function, you're giving it to a patient who can't break it down as efficiently as they could, and you're giving it to them in a very high dose. So that combination leads to the perfect storm. It's happened in a couple of cases with kids, and it's happened in some geriatric patients as well, where they had some negative outcomes in the dental chair. I don't want to get into it too much, but you get the idea that things didn't go very well. So I love lidocaine. I think it's a good agent. I think everybody uses lidocaine, and at 2%, I think it's, standard industrial, everybody uses lidocaine because that's lidocaine. But lidocaine's issue has always been the fact that it's only available with epi, and the pregnancy thing doesn't really give it as great an advantage as you might think, and Mepivacaine becomes the standard. Okay, now there's a couple of footnotes here. One, lidocaine is available with the 1 to 50,000 epinephrine. That's twice strength, if you will, or double strength that we use in our vernacular, right? What is that good for? Why would I want to give the 1 to 50,000? Well, I can think of one good reason why I'd want to use that, and that's hemostasis. Okay, and anybody who's listening to this who's used it will tell you that 1 to 50,000 epinephrine. Forget the lidocaine. It's not the lidocaine. It's the 1 to 50,000 epi with the lidocaine that does the job. So I kind of like that as a hemostat agent to keep around the office in case I really need it. Lots of people on anticoagulants these days. Lots of people use supplements that cause bleeding. Cannabis can increase the risk of bleeding. So, there's a bunch of reasons why we want to keep a hemostat around. But the other thing is Mepivacaine is available with a vasoconstrictor. As rare as it is, you can get carbocaine with a vasoconstrictor, but it's not epinephrine. It's levonorepinephrine, which, if you remember this stuff, neocabephrine, was a great vasoconstrictor because it had more alpha activity than beta. Okay, plain language, it didn't cause this. So if I can get something like epinephrine that doesn't cause tachycardia, I'm in, right? No, the levonorepinephrine did increase blood pressure in patients. So it was a mixed bag as well. The other problem with it was that when you added the levonorepinephrine, the concentration of Mepivacaine went from 3% to 2%. And so it sort of became mediocre. All that means is that you've got options, but this is why dental professionals love them fall into certain types of behavior. Like, I'm going to use what I know, what I'm comfortable with and familiar with. It's okay, but just make sure of the selected agents you chose to be your favorites, you've got enough to cover every patient with every specific or individual type of medical complication.
Tom, this has been amazing already. My head is spinning. And as you can imagine, if you're a GP listening to this, you got to check out his, supplemental stuff. He's got incredible education, and heck, even just follow him on social media. You're going to learn a ton. But is there any other agents that would be pretty important for us to know on this in scenarios involving those agents?
Well, patients, I can tell you, there are patients out there right now that would probably need another agent based on everything we just talked about. And there's going to be one agent that I talk about, and I'll mention the topicals as well. But the last injectable agent that I think deserves mention is Prilocaine or Citinest. If you took a look at Prilocaine from a 10,000 foot level, as I like to say, you look at it and say, well, this stuff's pretty good. I mean, Prilocaine, or Citinest as it's known, seems to have every advantage of every other anesthetic agent we just talked about. It's 4%, so it's twice as concentrated as, let's say, Lidocaine is in the cartridge. So that's like Septicaine, right? It's metabolized outside the liver to some extent, not the same extent as Articaine, but to some extent. And you can say, well, that's like Articaine, right? It's available plain. That's like Mepivacaine, right? And it's available with epinephrine, but with the 1 to 200,000 epinephrine. Oh, again, that's like Articaine. And it's category B. That's like Lidocaine. So it has almost every advantage we just talked about, all lumped together in one. So why wouldn't I want to use Prilocaine? Well, the problem with Prilocaine is the word that nobody likes to say because it has too many letters: methemoglobinemia. Now, again, you'd have to use large quantities of Prilocaine to really get methemoglobinemia. And usually that large quantity is at or above the maximum recommended dose of the MRD for the Prilocaine. But having said that, if the patient is at risk for hypoxia, they have COPD, congestive heart failure, if they're at risk for methemoglobinemia, maybe they already have it, maybe they were born with it, or if they're at risk for any kind of anemia, even iron deficiency anemia, sickle cell, all of those are relative contraindications. So while Prilocaine may be an amazing agent, this methemoglobinemia thing stands in the way of a lot of clinicians warming up to it. So most of them say, well, I can't remember all that. I'll just use Lidocaine. It's just easier. And of course, the Cinderella here, if you will, is Bupivacaine. We love Bupivacaine, right? Super long-acting agent, super potent. But again, much like Mepivacaine's downside was, Mepivacaine's advantage, Carbocaine's advantage is it's plain. Its disadvantage is it's plain. It's the same thing with Bupivacaine, or Marcaine, it used to be called. Marcaine's great advantage is it lasts forever, seemingly, right? It lasts for hours. But Marcaine's disadvantage is it lasts for hours. So it's limited in its application in dentistry. We love it for like third molar extractions. Heck, if I was going to do a procedure that was going to be very painful, like a third molar extraction or surgery, I'd want to use Bupivacaine, not because of the anesthetic effect during the procedure. I want to give somebody an injection of Bupivacaine after the procedure to keep them pain-free for hours, especially if I don't want to give them an opioid. But again, to me, those are the sort of outside agents, Prilocaine and Bupivacaine, because they have very specific applications in dentistry. Most dentists and hygienists and people in the industry that I know prefer Articaine, Lidocaine, and Mepivacaine as their top three. But I'm not saying those other agents aren't any good. They just have more specific applications. Topicals, Kirk, is where we should go next, because I want to make sure that people know about topicals. So I know everybody loves benzocaine. I'm sure you could agree. You've heard people love benzocaine topical. I like it too. But the problem with benzocaine is it may be inexpensive, maybe widespread. You can find benzocaine anywhere. But benzocaine may not be the best topical because, number one, it is an ester. So it can cause allergy. Now, we kind of bypass that by keeping the pH of the benzocaine preparations low, so it really doesn't cross into the bloodstream and doesn't cause the allergy. But if you apply enough, as some people do at home, they go to a drugstore and buy a couple of tubes of Oragel or Ambisol, and apply it all at once, you can get methemoglobinemia from benzocaine. And also because of the lower pH, you can burn the tissue significantly if you leave it on too long. So benzocaine may not be our ideal. As a matter of fact, I often tell moms and dads who use baby Oragel and Bambi-Aerosol, be careful, because sometimes that benzocaine can slide down the back of the baby's throat and anesthetize the gag reflex, which could be problematic in a newborn. But what are your options then if you don't want to use benzocaine? Well, I do like Oracix. We all love Oracix, right? Lidocaine and Prilocaine together. Eutectic mixture, right? We love it. Again, I wouldn't use it as a topical, but it has its application in dentistry, certainly. But to go beyond that, what kind of other topicals are out there? Well, we can build on that lidocaine, prilocaine, eutectic mixture. There is LPT out there, lidocaine, prilocaine, tetracaine. There's BLT, benzocaine, lidocaine, tetracaine. There's TAC, there's Profound, there's, the best darn topical, which is, lidocaine, prilocaine, tetracaine, and phenylephrine as a vasoconstrictor. So I guess my advice when it comes to topicals is don't be married to one topical, but don't forget about Lidocaine. And it's not because, I have a relationship with Lidocaine or not. I love Lidocaine because it is indeed 3 agents. It's benzocaine as the immediate acting, it's butaben as the intermediate acting, and it's tetracaine at the long acting. And all 3 combined as a liquid. If you're a hygienist listening to this, you may love Lidocaine because it penetrates into the pocket and provides that profound anesthesia without necessarily having to give an injection. So I know hygienists out there that love their specific topicals. There's many to choose from, and I know dentists that love their topicals. But I guess my greatest advice is don't be stuck with one, because again, based on the procedure and the patient, you may want to decide to use a different topical versus one size fits all for all your patients.
Mm-hmm. Tom, this is awesome. Any last thoughts you have on the anesthesia or anesthetic part of it? And I want you also to talk about some of the resources that you have that are available for everybody to utilize. And I would just highly encourage you to check that out. But any last thoughts you have on this?
Yep. My advice is, when in doubt, always take what you've learned in podcasts like this and courses like mine that you take, and realize that you're the clinician. At the end of the day, and I've said this many times, I'm my best Brooklyn accent, here it comes, ready? I don't want to be you. As in, I don't want to be you. You're the clinician. Make those ultimate decisions you make every day. Make those amazing clinical decisions you make every day. Don't let people like me sway you, but do your own research and come up with what you think, based on what I've said, is the right strategy for you, because not every anesthetic fits every patient, as you might imagine, okay? When in doubt, do the consult. I know it's time consuming. I know it's a pain in the neck. But remember, if you've got a knowledge of anesthesia, you can work with that clinician, medical doctor, nurse practitioner, whatever, and come up with the right solution for that patient to minimize adverse outcomes. And remember, just listening to this podcast alone, you've got enough information right now. Like, you can bypass lots of problems, okay? Patient can't have epi. Okay, Tom said I can use Mepivacaine or I can use Citinest, okay? Patient can't have sulfites. Okay, well, then you need something without epinephrine. This patient has compromised liver function. Okay, but I would use Articaine or I might use Citinest. Just the number of facts you learned in this, short podcast is enough to help you make those decisions, along with the consult when necessary. I've said this 1,000 times. You've never worked on such medically complex patients before. This is your time to really use pharmacology as a tool to say, okay, I may not know a lot about this patient, but I do know the drugs they're taking. I do know what those drugs are used to treat. They've given me enough information about their medical history to know what the complications may be. Now I've got to go choose an anesthetic agent based on what I've learned and based on my own research. I think this is the right one. Let me call the clinician. Let me call the GP. Let me call someone and make sure that we're all on the same page here, because at the end of the day, we're responsible for our patients' health. Yes, we work in dentistry. Yes, our patients say, you're working on this. Why do you need to know about this? But at the end of the day, we're responsible for their health, and we've got to make those great clinical decisions. If you ever need to reach out to me for anything, if you need, I would love to provide you with education and information. Find me, okay? The best place to find me is on my website. And that's because I don't have a creative bone in my body. I named it after me. So it's tomviola.com. As hard as that may be, it's 8 letters, folks. You can do it, okay? tomviola.com. And seek me out. I've got podcasts you can listen to. I've got newsletters you can read. I've got courses you can take for CE credits. I've got resources that I would love for you to take advantage of, because at the end of the day, I feel like I've done my job. Dentistry's been so good to me. This is my way of giving back. So use my website as a resource. Call me. My phone number is on my website. Shoot me an email. Say, hey, Tom, I have this question. Tom@tomviola.com. Doesn't get any easier than that. But do seek me out. If you want to reach out to me on social media, you can find me everywhere. I'm on all the social media platforms at Pharmacology Declassified. Why? Because I wanted you to type as many letters as humanly possible. Because at the end of the day, that's the name of the company. So find me at Pharmacology Declassified. Reach out to me, make contact, read my posts and my blogs and all that stuff, and anything I can do to help. And by all means, come see me. I'm at almost every major dental conference going forward: Pacific Northwest, Greater New York, the Yankee Dental Congress, Chicago Midwinter, Hinman. So come see me at my courses. Sometimes I've got empty chairs, as few as they are, and I'm like, those chairs should be full, not because it makes me feel good, but because you could be sitting in there and learning about pharmacology and make it practical every day.
Amen, brother. And ADA, you're going to be at all of them.
ADA, can't forget ADA. That's right.
Don't admit yourself to that. Like I said, if you're a study club director and you're looking for a great speaker to mix things up, bring some great value, Viola's your guy. So make sure you can connect with him. And Tom, I just appreciate you so much, and I learn so much every time we chat, and I'm going to have you back again and again and again. So stick around while we say goodbye to everybody else. If you're listening to this podcast right now and you enjoyed it like we did, do us a favor, just hit the share button, share with your friends. Keep sending us suggestions for things that you guys want to hear on the podcast, because I'm going to have Viola back many times. What's your toughest thing to deal with, or what would you like to know more about? And you're going to see I can get this guy to talk for hours, more than I can talk, which is to say a lot. So, buddy, I am so grateful. So thank you so much, my friend.
Hey, I'm looking forward to seeing you at ADA. ADA has been great to me. They give me a whole corner just for pharmacology. So come on out, man, and come see me. And I've got little kiosks set up with quick Q&A and challenge the pharmacy guy. So that'd be great. Come out and see me. Love to see you there.
It's going to be fun. It is going to be a great time. And I'm thankful for you guys listening. The viewership and subscriptions just keep growing. So keep sharing this with your friends. And until we see you guys hear from us next time, keep watching or listening to the Best Practices Show. You guys enjoy the rest of your day.
Thanks, everybody.
Thank you.